My take on positioning therapies in inflammatory bowel disease is we all recognize there's a science to it and there's an art associated with that part. So I'll try to summarize evidence on efficacy and effectiveness of these medications from a multitude of sources, the safety of therapies. I'll try to put all of these together and present my approach to treating patients with moderate to severe Crohn's disease and ulcerative colitis in 2023. I fully recognize if I come back here next year in 2024 and 2025, these slides will be updated because the field is so rapidly evolving. These are my conflicts. Again, 3 take-home points. We are moving gradually from a TNF era to a non-TNF era, but I'll question here is that a wise thing to do? And maybe we should be cautious before jumping and calling all anti-TNFs evil. The future is definitely jacked up if the JAKs can tone it down. And finally, the whole idea of the right drug, right patient at the right time. Is there a road to utopia? Can we personalize therapies with predictive biomarkers? This is my core conceptual model for this entire discussion, and this is what I follow for each and every single patient seen in clinic. We know and recognize that IBD is a heterogeneous disease. The first and foremost thing when looking at patients in my clinic is I try to ascertain what is the likelihood that this patient is going to run into trouble because of their disease. So what is the risk of disease-related complications? Once I have this established, I add in the other cogwheels of the patient's risk of treatment complications, the intrinsic efficacy and safety of different therapies, and try to contextualize everything through that process. And the goal for all of us is to achieve favorable outcomes, which is sustained remission, avoidance of disease complications and surgery, while at the same time avoiding treatment complications and infections, and avoiding disability for all our patients with IBD. I'll center my talk around most of these aspects. We know and recognize that over the last 5 years, the treatment pipeline for IBD has exploded. We are fortunate to be living in this era because when I was doing my fellowship, anti-TNF therapy was the only medication that was available. But over the last 5 years, there have been an explosion of a multitude of non-TNF medications for treatment of inflammatory bowel diseases. First class of medication is the S1P modulators, of which ozanimod has been approved for ulcerative colitis, and phase 3 data for etrasimod was presented. Again, these are medications that sequester lymphocytes in lymph nodes. So in a way, lymphocyte trafficking inhibitors similar to anti-integrin agents, at least in my mind. The former ones are oral medications. Another class of medications, which is a selective IL-23 antagonist, of which risankizumab has been approved for Crohn's disease. All of these other medications are in advanced phases of development for ulcerative colitis as well as Crohn's disease. These again are targeting a specific cytokine, which is interleukin-23, and minimizing inflammation as a result. This class of medication, which I think has been game-changing, have been these JAK inhibitors, in particular the JAK1 inhibitors, of which 3 have been approved. Upadacitinib has been approved for ulcerative colitis and Crohn's disease. Tofacitinib is approved for ulcerative colitis. Filgotinib is approved for ulcerative colitis in Europe, not in the United States. It has not been approved for Crohn's disease, is unlikely to be approved for Crohn's disease. These again are signaling inhibitors blocking Janus kinase enzymes. And finally, the anti-integrin agents, of which we're all very familiar with, vedolizumab, which is approved for Crohn's disease and ulcerative colitis, which block lymphocyte trafficking to the gut. The only failure in this entire process has been etrolizumab, though I would commend the company for being very ambitious in their clinical trial program, looking at a bunch of head-to-head clinical trials, which I think has been informative for a lot of things that we talk about. So let's talk about comparative efficacy and positioning of current therapies for the management of IBD. I'll first present data for Crohn's disease, including the efficacy and safety of therapies. I'll subsequently move on to ulcerative colitis. I'll tie in additional data and update all of those things with new data related to upadacitinib, which I think has been game-changing. This is data for Crohn's disease looking at the efficacy of these medications for induction of therapy. I want to emphasize the single most important prognostic factor as to how well a medication works is prior anti-TNF exposure. So always think about the efficacy of these medications in the context of whether they're naive to anti-TNF therapy or exposed to anti-TNF therapy. If we line all of these pivotal clinical trials for medications for Crohn's disease, we start to see some differences between different medications. I will confess the infliximab data looks too good, but the infliximab trials were not generally designed as most contemporary trials are. The certolizumab pegol data, the delta over placebo, does not seem to be very high, and I highlight this here. Certolizumab pegol is actually not approved in Canada or in Europe. In the United States, it's approved only for maintenance of remission, not necessarily approved for induction therapy, which is a weird situation. We see data for vedolizumab, ustekinumab, and risankizumab. So how do we think about comparative efficacy? Perhaps the gold standard way of looking at this thing is head-to-head trials. Unfortunately, there have been only a few head-to-head trials in the field, one of which was presented last year, published in The Lancet. This was the CView trial comparing ustekinumab to adalimumab in patients with moderate to severely active Crohn's disease in patients who were otherwise biologic naive. This trial was designed to demonstrate superiority of ustekinumab over adalimumab. What the investigators, however, observed is that there is no difference in rates of achieving clinical remission between ustekinumab and adalimumab. So technically, this was a negative trial and did not demonstrate superiority of ustekinumab over adalimumab. Part of the reason was the investigators felt that the rates of achievement of remission in placebo-controlled trials have generally been close to 40%. However, what we observed in a head-to-head trial is when you look at a clinical remission endpoint based on CDAI, overall rates of achieving clinical remission were closer to 60%, which is probably akin to what we see in our clinical practice as opposed to 40% rates of achieving clinical remission. I do want to emphasize that this trial was only looking at monotherapy for ustekinumab and adalimumab, and we know and recognize that probably the best way to use anti-TNF therapy is in combination with thiopurines or methotrexate, just because that is a more immunogenic target and the likelihood of developing immunogenicity is higher. How do we take it a step further? How do we move from head-to-head trials to inform comparative efficacy of different medications? And this is where the idea of what we call a network meta-analysis comes in. We're familiar with head-to-head trials. We're familiar with traditional meta-analysis where two medications that may have been compared with each other can be summarized through a meta-analysis. What a network meta-analysis allows you to do is look at the probabilistic relationship based on indirect comparisons. So two medications that have been compared to placebo in trials that are otherwise very similar to each other, including similar patients and co-interventions, you can look at the probabilistic relationship between different medications. This has been tremendously used in a lot of other fields, and we've started using it in patients with inflammatory bowel disease. And what we observed here in the blue bar is the medications that tend to stand out in a subset of biologic naive patients are infliximab in combination with thiopurines or infliximab monotherapy, which seem to be the most efficacious therapy for treatment of biologic naive patients with Crohn's disease. In a subset of patients who have had prior exposure to biologics, the two classes of medications that tend to stand out are ustekinumab and risankizumab. So the IL-23 antagonists are probably more efficacious than some of the other medications in a subset of patients who have had prior exposure to anti-TNF therapy. What about endoscopic outcomes? This is again looking at individual participant level data from clinical trials and looking at the effectiveness of these biologics in achieving endoscopic outcomes for patients with Crohn's disease. Work done by Neeraj Narula, and what they consistently observed is anti-TNF therapy is associated with higher rates of achieving endoscopic outcomes as compared to vedolizumab if you look at individual participant level data. The rates were also higher for ustekinumab as compared to vedolizumab, although this was not statistically significant. So we're starting to see some data for effectiveness of these medications where anti-TNF therapy for most patients with Crohn's disease is still the most efficacious medication. In a subset of patients who've had prior exposure to anti-TNF therapy, IL-23 antagonists may be an effective medication, perhaps more efficacious than vedolizumab in this situation. Let's talk about safety, because that is the second factor that goes into making treatment decisions. We're all familiar with a safety pyramid based on the intrinsic immune suppression potential for these medications. But I will argue that there are two factors that influence safety of a medication. One of them is the intrinsic immune suppression potential of a medication. So a gut-selective medication like vedolizumab is probably the safest in terms of suppressing the immune system as compared to broader medications like anti-TNF therapy. However, that is just one part of the picture, because the other factor that plays into safety of a medication and the risk of serious infections is effectiveness of the medication in controlling disease. And I will argue that this influences the short-term risk of infections. For a patient sitting in front of you, they're not specifically keen on the overall safety of a specific medication. For a patient, what matters is the safety of a treatment strategy or a treatment approach rather than an absolute risk of safety with a specific medication. So the data that I'll show you next will make an argument that it's the safety of a treatment strategy that is more relevant as compared to safety of a specific agent. So this was an observational comparative safety study that we did comparing anti-TNF therapy and vedolizumab in patients with inflammatory bowel diseases. Our a priori hypothesis going into this study was vedolizumab works really well for ulcerative colitis. I will show you that data. So we thought, as compared to anti-TNF therapy in a subset of patients with ulcerative colitis, where two medications work equally well, a medication that does not suppress the immune system that much is going to be safer in terms of risk of serious infections. However, in a subset of patients with Crohn's disease, based on the data that I just showed you, based on clinical trials, network meta-analysis, I did not show you observational data, but again, consistently showing that vedolizumab may not be as effective for Crohn's disease as it is for ulcerative colitis. We argue that anti-TNF therapy may actually end up being safer, or at least there'll be no differences in the risk of serious infections between these two medications. And that is actually what we observed. So this is data from that study comparing vedolizumab versus anti-TNF therapy and the risk of serious infections. If you look at all patients with inflammatory bowel diseases, there's no difference between vedolizumab and anti-TNF therapy for the risk of serious infections. But if you break it down by ulcerative colitis and Crohn's disease, vedolizumab was clearly associated with roughly a 50% lower risk of serious infections. However, for Crohn's disease, there was no difference. If anything, the risk of serious infections was 1.3 times higher for Crohn's disease with vedolizumab. We then broke it down by extraintestinal infections versus GI infections. And the intention here was GI infections is probably representing disease-related infections, perianal abscesses, intra-abdominal abscesses, C. diff. And what we observed here is that vedolizumab was actually associated with an increase in the risk of GI serious infections in patients with Crohn's disease compared to anti-TNF therapy, leading us to infer that vedolizumab is safer than anti-TNF therapy for patients with ulcerative colitis, but there may not be much of a difference in the risk of serious infections when it comes to Crohn's disease. This wasn't just us. We subsequently followed it up with a meta-analysis of 20 head-to-head observational studies and data from 17 cohort studies with close to around 52,000 patients consistently demonstrate that there is no difference in the risk of serious infections between vedolizumab and anti-TNF therapy for Crohn's disease. For patients with ulcerative colitis, there is clearly a safety advantage with vedolizumab with a 32% lower risk of serious infections. Looking at ustekinumab versus anti-TNF therapy and ustekinumab versus vedolizumab therapy, again, a similar theme. We demonstrated that ustekinumab and overall the IL-23 class seems to be similar to anti-TNF therapy when it comes to treatment efficacy. And here, by virtue of being less immune suppressive, in patients with Crohn's disease, we observed that ustekinumab is associated with roughly a 50 to 60% lower risk of serious infections versus anti-TNF therapy, as well as against vedolizumab. For ulcerative colitis, the data on IL-23 antagonist is still lacking. So overall, the conclusion here was that the safety profile of advanced therapies varies and influenced by both treatment effectiveness as well as intrinsic immune suppression. So this is a question that often comes up in my clinical practice, and this is something that I talk to all my fellows about. When trying to choose a specific medication, should we focus on effectiveness or safety of a treatment? And what I say that we should almost always choose a more effective medication over a conceivably safer medication. Again, all of this is put in the context of the patient's risk of disease complications. That is the number one thing when you're seeing a patient, trying to ascertain what is the likelihood that this patient's disease is having a significant impact on them right now, and what is the likelihood that this is a patient that will have subsequent complications down the line from their disease. And once you understand that part, always choose a more effective medication rather than going for a safer treatment strategy. A lot of people come about and say, what about the risk of malignancy? That is a number one thing that patients are concerned about. I tell them that we should always contextualize all risk of malignancy with these medications. Risk of malignancy like lymphoma with anti-TNF therapy is about 1 in 2,500. A patient who is getting to the point of needing anti-TNF therapy, if they do not go on a biologic medication, the risk of surgery is about 1 in 5. So think about somebody whose disease is severe enough to require a biologic therapy or an advanced therapy. The risk of surgery is 1 in 5. Their conceivable risk of a malignancy like lymphoma is 1 in 2,500. So the risk of malignancy is sometimes overblown, and it is our responsibility to contextualize those risks for our patients rather than giving in to the fact that these medications are not safe. So how did we use all of this data to inform the AGA guidelines on the management of moderate to severe luminal and perianal fistulizing Crohn's disease? I'm just going to be presenting data or presenting the recommendations as it pertain to positioning therapies. For patients with moderate to severe Crohn's disease who are naive to biologics, the AGA recommends the use of infliximab, adalimumab, or ustekinumab over certolizumab pegol. Again, certolizumab pegol is probably underdosed for the way it was approved for treatment of Crohn's disease, and all of these other agents are more efficacious than certolizumab pegol. The evidence for vedolizumab being more effective than certolizumab was somewhat low certainty, and hence a conditional recommendation of that being a good treatment option. If you start looking at a subset of patients with prior exposure to anti-TNF therapy, a subset of patients who have never responded to anti-TNF therapy, i.e. these are patients with primary non-response, here the AGA strongly recommends the use of ustekinumab. However, vedolizumab is a reasonable alternative in these patients. In a subset of patients who may have had a prior response to infliximab or adalimumab and subsequently either developed secondary loss of response due to low trough concentrations or immunogenicity or had intolerance to their first anti-TNF therapy, both adalimumab or ustekinumab would be good treatment options. In general, for a patient like this, I generally go to adalimumab for a subset of patients who have demonstrated excellent response to infliximab and then developed immunogenicity. Let's move to ulcerative colitis. Again, similar breakdown. I'll probably not go into as much detail here because you know the overall data that was informing this part was also derived similarly. Again, putting all of these medications next to each other, clear the delta over placebo seems to be high for infliximab and vedolizumab. Similar approach used for the AGA guidelines, looking at data for efficacy of a medication based on head-to-head trials, as well as network meta-analysis, and putting this in the context of safety of medications. Here, what the guidelines suggested is that patients with moderate to severe ulcerative colitis who are naive to biologics, the AGA suggests the use of infliximab or vedolizumab rather than adalimumab for most patients with ulcerative colitis. However, a subset of patients who value subcutaneous therapy or the convenience of self-injectables over the potential lower efficacy of adalimumab may reasonably choose adalimumab as an alternative. In a subset of patients who have never responded to infliximab, data from network meta-analysis would suggest that a medication like ustekinumab or tofacitinib seems to be more efficacious than vedolizumab or adalimumab. Here again, this is not set in stone. A subset of patients who value the safety of vedolizumab may reasonably choose vedolizumab in this situation after failure of infliximab. So this is data for basically demonstrating, again, everything that you see here does not include JAK1 inhibitors. This is me arguing that anti-TNF therapy is still probably one of our best medications that we have for treatment of inflammatory bowel diseases. What I'll show you next is what I think is a game-changing medication which significantly modifies our approach to treatment of inflammatory bowel diseases. And this is the specific medication, the upadacitinib, which was approved for ulcerative colitis last year and approved for Crohn's disease last month. This selective JAK1 inhibitor seems to have the highest efficacy in achieving induction of remission in patients with ulcerative colitis. This pivotal phase 3 studies demonstrated that a delta over placebo with upadacitinib for ulcerative colitis was close to around 20-25%, similar to infliximab maybe, but significantly higher than most other medications where the delta over placebo is more closer to around 10% for adalimumab, 15% for the IL-12/23 or IL-23 antagonists. So upadacitinib seems to have a higher efficacy compared to most other medications. And this is what data from an updated network meta-analysis would seem to suggest. Again, I'm not asking you to look at this entire table, but what I want to emphasize here is the lines that have been bolded and in blue demonstrate statistically significant higher rates of induction of clinical remission and endoscopic improvement. Up at the corners is upadacitinib, and what you see across the board, across all medications, upadacitinib seems to be more efficacious in achieving clinical remission as well as endoscopic improvement in patients with ulcerative colitis. What about data for Crohn's disease? Again, this was just published in the New England Journal of Medicine last month. The UXE and the UXL studies demonstrating higher rates of achieving clinical remission with upadacitinib compared to placebo, both in a subset of biologic naive as well as biologic exposed patients, leading to the approval of this medication. And again, updated data from a network meta-analysis in a subset of biologic exposed patients here. Again, two medications tend to stand out, and that's risankizumab and upadacitinib. Both of them seem to be equally efficacious in a subset of patients with prior anti-TNF therapy. So what I'm saying is for ulcerative colitis, upadacitinib seems to be a logical choice, especially in a subset of patients who've had prior failure of anti-TNF therapy. And if you have the ability to use it as first line, I'll show you data on the next line with the Death-Nell right now, which keeps us from using upadacitinib as first-line therapy for ulcerative colitis. However, in a subset of patients with Crohn's disease with prior exposure to anti-TNF therapy, both IL-23 antagonists as well as upadacitinib may be reasonable treatment options. So why is it that we can't use JAK inhibitors as first-line therapy for patients with inflammatory bowel disease? And this was the oral surveillance study which resulted in the FDA taking that, our ability to use that as first-line therapy away. Again, this was designed to look at the safety of tofacitinib as compared to anti-TNF therapy in patients with rheumatoid arthritis who were older than the age of 50 with at least one cardiovascular risk factor. Large study, and what they observed here is that tofacitinib, particularly at higher doses, was associated with a higher risk of major adverse cardiovascular events as well as malignancies as compared to anti-TNF therapy, and across a multitude of secondary outcomes, including serious infections, opportunistic infections, pulmonary and venous thromboembolism, as well as death. The risk was higher with JAK inhibitors at high doses compared to anti-TNF therapy, which led the FDA to issue this black box warning of an increase in the risk of serious heart-related events, cancer, blood clots, and death with JAK inhibitors, and arguing that at this point, they're limiting all approved uses of JAK inhibitors. So it wasn't just for tofacitinib, they extended it to all approved JAK inhibitors, including upadacitinib, to certain patients who have not responded to or cannot tolerate one or more anti-TNF therapies. As a result, because of this FDA warning, upadacitinib, tofacitinib are all only reserved for a subset of patients who've had prior anti-TNF exposure. The European Medical Agency has taken a different approach, which they say that these risk of cardiovascular events, pulmonary thromboembolism, is highest in a subset of older patients above the age of 60 or those who are smokers. And they said, in that group of patients, avoid using it as first line, but they do allow the use of upadacitinib as first line therapy in all other patients. So I think over time, as data accumulates for our patients with IBD, where the inherent risk of a lot of these events is perhaps lower than older patients with rheumatoid arthritis, I think that part will evolve. So this is me summarizing 2023, my approach in my clinic for treatment of moderate to severe Crohn's disease and ulcerative colitis. Again, like I said, always think about the risk of disease complications and risk of treatment complications. Always factor in patients' values and preferences, logistics, lifestyle, speed of onset, cost of therapy. For patients with severe disease, those with high structural damage because of their Crohn's disease, patients with deep ulcers, extensive disease, prior complications, prior surgeries, those who have a high inflammatory burden or whose disease is having a significant impact on quality of life, my first-line therapy is typically infliximab or adalimumab. When I'm using these agents, for the most part, I'm trying to use it in combination with thiopurines. In a subset of patients who have significant comorbidities or contraindications, I use risankizumab or ustekinumab in those patients. The CView trial hasn't necessarily changed my practice to use ustekinumab as first-line therapy, just because I think there's a vast majority of real-world experience with infliximab and adalimumab for most patients with Crohn's disease. In patients with prior exposure or prior failure of infliximab or adalimumab, my typical second-line agent is most likely risankizumab or ustekinumab. I've added upadacitinib as a treatment option in those patients. I generally tend to go with IL-23 antagonist before I go to upadacitinib, unless my patient has higher likelihood of drug wasting. In a subset of patients who have immunogenicity to infliximab or intolerance to infliximab, I will typically go to a second anti-TNF therapy. I would preferentially use adalimumab in those patients, generally in combination with thiopurines. In a subset of patients with frailty, prior serious infections, recent malignancy, where they have multiple comorbidities, I tend to use risankizumab or ustekinumab as my first-line agent. I may use vedolizumab in a subset of patients who have limited disease. Second-line therapy in these situations is typically monotherapy with anti-TNF agents. Similar approach for ulcerative colitis, again, factoring on all of these things. Again, patients with high structural damage, high inflammatory burden, significant impact of the disease on quality of life. My typical first-line agent is vedolizumab in these situations, especially if they have moderate disease, if they do not have a lot of extraintestinal manifestations. The more severe the disease, the more likely I'm going to be using infliximab in these patients, generally in combination with immunomodulators. I do consider ustekinumab in a subset of patients who have significant contraindications to anti-TNF therapy. However, in most situations, I'll end up using vedolizumab rather than ustekinumab as first-line agent. Second-line therapy, again, depends on what my first-line therapy was. If my first-line therapy was vedolizumab, I typically would go to infliximab as my second-line agent in those patients. If, however, my first-line therapy was infliximab, I'm invariably going to upadacitinib in these patients. My use of tofacitinib has gone down significantly just because the efficacy data for upadacitinib applies also for patients with prior exposure or prior failure of tofacitinib. So there's real-world experience coming out from centers like University of Chicago, Mass General, all of which show that even in a subset of patients who may have responded perhaps to the 10 milligram BID dose of tofacitinib initially with induction, when subsequently lose response as we come down to 5 milligrams BID, or those who even do not have a response to 10 milligram BID tofacitinib will still respond to upadacitinib. So in general, I use upadacitinib as my second-line agent if the first-line agent was infliximab. Again, patients with significant risk of treatment complications who are risk-averse, my first-line agent is generally vedolizumab or ustekinumab. Unlike Crohn's disease, at this point, I'm uncertain whether IL-23 antagonists will be any better or different than ustekinumab. I do think for Crohn's disease, there is some signal that IL-23 antagonists may be a touch better than ustekinumab. Again, there are head-to-head trials that are ongoing that will inform this piece better. But based on the data that we've seen for mirikizumab, guselkumab, may not be too different with as compared to ustekinumab. Second-line therapy in these situations is either infliximab monotherapy or upadacitinib. All right. What about the road to utopia? Can we get to right drug, right patient, right time? Again, the field is rapidly evolving. The whole idea of IBD matchmaking with rational combination therapy, proof of concept studies suggesting that this may work. There may be medications like JAK inhibitors and IL-23, which have really overlapping effects. So logically may not make sense to combine these two medications. But JAK inhibitors with trafficking agents or IL-23 agents with trafficking inhibitors may have a little bit of a complementary effect, or either of these medications with anti-TNF therapy may have synergistic effect. And this was data from the proof of concept phase 2 VEGA study, which was combining guselkumab with golimumab in patients with ulcerative colitis compared to monotherapy with either. And what we observed is that the combination of the two agents seems to work better than monotherapy with either of these agents. So this is a field that is rapidly evolving, and we'll have better understanding of rationally combining these medications. The other area where there's a significant need and a move is this idea of predictive and prognostic biomarkers. Prognostic biomarkers are drug agnostic, and which primarily focus on identifying which are the patients that are going to get into trouble. So who are the patients who have aggressive disease versus who are the patients who will have a more indolent course? And again, like I said, that is the number one factor that influences my approach to treatment. So these prognostic biomarkers and associated clinical trials are ongoing and will be informative. And the whole idea of predictive biomarkers, which will tell us, if a patient has this biomarker, use this medication, that is where we want to eventually get to, and that'll help us choose one medication over another significantly. Again, there's a lot of promise in terms of what are factors that may determine response to therapy. What likely determines response to therapy are these whole multi-omic factors, the microbiome, metabolome, exposome. Unfortunately, that field, again, there's a lot of science studies going on. At this point, what we know for sure is that the clinical phenotype and clear pharmacological factors that identify patients more or less likely to respond to all medications, not to a specific medications. So patients with milder disease, no prior exposure to anti-TNF therapy, colonic disease location may be more likely to respond better, or patients who respond quickly are more likely to achieve durable remission, whereas patients with more complicated phenotype are less likely to respond. I do want to end this with one very promising medication, at least in phase 2 studies, which is focused on this idea of a predictive biomarker. So this was Prometheus Biosciences looking at PRA023, accompanied by a companion diagnostic. So this is a monoclonal antibody targeting TL1A, supposed to be anti-inflammatory and anti-fibrotic. This is data for ulcerative colitis. Again, delta over placebo close to around 25%, similar to upadacitinib. Again, I will confess that this is a phase 2 study. Sometimes those are overly optimistic, so be mindful of that part. But what I want you to focus on the right of the screen, which looks at patients who had a companion diagnostic. So patients with a specific biomarker, there were differences in the likelihood of response to this medication. So patients who were expressing this specific biomarker, their delta over placebo was close to around 40%. So you can imagine all of a sudden, if this is a biomarker that is expressed by patients and seems to be specific to this medication, for patients who express this biomarker, a significantly high likelihood of achieving remission. It did seem to perform well even in a subset of patients who did not have this biomarker. But again, this is where the field is evolving, and we'll have a good understanding from subsequent phase 3 studies. I'll end on this side. There are both clinical and scientific advances that are going on that will help us break this therapeutic ceiling of a 40% rates of achieving remission. And this may involve novel combinations of medications, prognosticating disease and predicting biomarkers, as well as more target-driven management in routine clinical practice. So my take home, I think TNF antagonists are still one of the best options for Crohn's disease and patients with severe ulcerative colitis. I think JAK1 inhibitors are potentially game-changing oral therapies for ulcerative colitis. I think the road to utopia is long. Till then, mass personalization based on comparative efficacy and safety is better than playing the lottery. With that, I'll stop, and I'll be happy to take questions.